So I've been here about 11 years now. As Ron said, I came to do my ID fellowship and fell in love with Chapel Hill and the department, the infectious disease department here, and have stayed ever since, and will stay as long as they keep me. So my career, or my daily life, is varied. One of the things I love about ID is that it is varied. I spend most of my time doing research, and we can talk about that after this as well. I do really research on both primary and secondary prevention of HIV, really with young MSM of color, young men who have sex with men of color, trying to keep those that are uninfected, and for those that are infected, trying to get them into care and keep them in care. And I do that using things like the internet and text messaging, designing sort of interventions. Right now we're working to design some mobile apps, things that sort of are trying to reach a population using innovative ways. So I had to put down Ron told me I had to put down my phone too, so I'm a little nervous without holding my iPhone right now, but I'll bend to his rules. So that's sort of the research I do. I also take care of patients, and that's really sort of, I think, where this talk comes. I actually had clinic today. I see patients in the ID clinic here 1 day a week, taking care of patients, and also do some time on the inpatient wards, taking care of really patients of all medical issues, but also with HIV. So I'm talking about treatment and clinical manifestations. I know this is called the AIDS course, and I would actually lobby to change it to the HIV course, because when we talk about treatment and we talk about the sort of what is HIV, what does it look like today, it's not a lot of AIDS, at least in this country, and I think that's a really great thing. We see it, but we don't see it as much, and the places where we do see it tends to be sort of different. I see much more on those 2 weeks that when I'm in the inpatient service that I do probably in 6 months in my clinic, and I think that's a great thing. So we'll talk a little bit about sort of the manifestations of HIV today. I'll also give you a little bit of a background on sort of some of the things that you could see, in terms of sort of old school HIV, and then leave plenty of time for questions, or I don't know if you're allowed to leave early, but either way, I won't talk your ear off for an hour and 20 minutes because I don't have any water. So, and Julian wouldn't give me his Red Bull. So, all right. So where are we with HIV? Well, the really great thing is we have lots of medicines to treat HIV. And the beauty of our medicines is that they're easy to take. So we've come a long way since the first cases 30 years ago, really unlike any other disease, and I think in modern history, where we've made such advances in terms of how we treat the infection, not just sort of in treating it from our standpoint, the doctor's standpoint. All we care about really is getting rid of it or doing getting patients better. Patients care about, well, I don't know if I really want to get better if I have to take, handfuls of pills 3 times a day. I don't know if I really want to do that. Is the disease, or the treatment worse than the disease? So for patients, they want not only to sort of be better, but they want something that they can incorporate into their daily lives. And we've come a long way, and we'll talk about that. The drugs have gotten better, all right? So when we first started, there were sort of low potency, AZT, the first drug that came out, it didn't work great. Part of that is because it was one drug. We now know you have to not only use one drug, you have to use probably at least 3 drugs. There's some debate about maybe using 2, but really the gold standard is 3 drugs targeted against the virus. And the drugs we have now, the sort of cocktail, so to speak, which really all cocktail means is we're mixing things together, just like they do in cocktails. They're better tolerated and they're more powerful. And we can get them to our patients, all right? The AIDS Drug Assistance Program, or ADAP, even for patients that don't have money, we can get them medications. Even when there was ADAP shortages and waiting lists here, we were able to get them on some pharmaceutical treatment plans. So the good news is, at least today, that may not always be the case, and I think clearly I won't politicize the talk because it's being recorded, and I may run for office someday, but not really. I would not pass. Although, well, I'll stop. I'll stop right now. But generally, we can get the medicines for those that we need them. And people live long, healthy lives, okay? I think that Somebody's waving to me up there. I think that this, the first question I get asked, and I see a lot of young people. I would say that my mean age of new patients is probably 21, 22, 23 years. I saw a new guy today, 24 years. Again, I think my patients are getting old when they're like 27. So, my patients are young guys, and, they are going to live long, healthy lives from the HIV standpoint. Now, that means getting off, smoking as much weed as they smoke, and, cutting down on the cigarettes, and, not driving, drunk, and all of these other things that I tell them are going to much more likely impact their survival than HIV if they sort of do all the things that we talk about. More people are getting tested, all right, but not enough people are getting tested, all right? We still know that probably 20% of people who are HIV infected in this country don't know their status. We also know that people who don't know their status are more likely to spread the disease. So if you look at estimates, it's estimated that about the 20% of people who don't know their status are probably responsible for more than 55% of the spread of HIV. If you don't know you're infected, you're probably not going to take steps to reduce your risk of transmitting HIV because you don't know, all right? Not everyone uses condoms. I won't do a poll or walk up and interview people, but because I'm not allowed to leave this space. But, we don't all use condoms every time we have sex. And, that's just the way it is. But if you know you're HIV infected, you're much more likely to use a condom. So it really is important to get people tested. Where are the negatives? Well, again, the people that I see that don't do well are the people that don't engage in care for whatever reason. And there's a lot of reasons. There's still a lot of stigma. There's a lot of other competing needs that people have. Taking care of their families, holding down a job, that don't necessarily jive with coming to the clinic. All right? And so they sort of say, I feel fine. I don't need to be seen until they don't feel fine. All right? And so people also, we know that people with HIV are more likely to use drugs, alcohol, have depression, mental health issues. Again, it limits their ability to do the things they need to do to take care of themselves. New infections continue, all right? We'll talk a little bit about that. But, people are still getting infected. Despite all of the work we do in prevention, people are still getting infected, all right? We haven't made huge dents. There's been some recent progress in prevention of infections, really around treatment. And so we'll talk a little bit. People are getting older, all right? So what we're seeing is that while people live long, healthy lives, now we're seeing our HIV-infected population with all of the sort of issues that we saw sort of in other aging populations, and the HIV providers are maybe not the best ones to be dealing with it. Most of us went into infectious diseases because we like sort of acute diseases, and to make that diagnosis and put them on the right medicine and move on. And most of us are now primary care doctors. I mean, today I talked to someone about their alcohol use, their cholesterol, a lot about sex, but those were the other sort of things that we sort of talked about, getting their screening exams, all these things that, again, I didn't necessarily pay that much attention in medical school to the kidneys and the heart and all that stuff. So, we're having to learn all that. What we also see is that people can acquire HIV that already has mutations, all right? So that the HIV they get is already not as susceptible to some of the medicines we have, and we see that in about 15% of our newly infected patients. A lot of that comes from being transmitted from people who were on medicines and then stopped. So there's still a lot of work to be done. But we've improved, all right? So if you look at sort of the regimens, 10 years ago, this is sort of what we saw, a handful of pills. If I present my, 18-year-old newly diagnosed kid with that handful of pills and say, can you take these pills 3 times a day, every 8 hours? They're going to look at me like I'm crazy. I mean, I couldn't take medicines 3 times a day. I, had a hard time taking prenatal vitamin when I was pregnant. Again, I think we have to sort of think about that. The good news is that we now have 1 pill once a day treatment for HIV, all right? We actually have 2 different therapies that are 1 pill once a day, and we have more coming along the pipeline. So again, if you tell somebody who's newly diagnosed, you think you could take a vitamin? I could take a vitamin. Well, how many times is a vitamin? Well, it's 1 pill a day. What if, that vitamin was called a tripla? Could you do it? And there, all of a sudden there's, I think, as I like to say, there's something magical about being able to treat HIV with 1 pill. I think there's just, there's not a huge amount of difference between taking 1 pill a day and taking 3 pills 1 time a day, really, in terms of how much work. but there's something sort of inherently magical about treating it with 1 pill a day. How long can somebody live? It's, again, a question I always get. And, as I tell people, all of these studies are based on, data that have been collected over time, and, you sort of project life expectancy. And, I can't look at any one of you and say how long you're going to live. All right? I don't know. If I could predict that, I guess I'd sell insurance or something. But we can't predict that. But what you can sort of say is that, if the stars align and you do well from your HIV by getting on meds, your life expectancy shouldn't be significantly different. Now, some studies say it's about 7 years less. Again, but what we have to factor in is that what we know is that people with HIV are more likely to smoke. They're more likely to use alcohol and drugs. They're more likely to live in poor neighborhoods and have lower socioeconomic status. They're more likely to face stigma and discrimination. So all of these things probably affect their life expectancy more than their HIV. But what we know is that, again, somebody who is diagnosed today, a 35-year-old man diagnosed today, would expect to live into their 70s. Same thing with a 20-year-old. So again, not a whole big difference in life expectancy. And again, this is sort of the standard CDC slide that we all have to show. But what it shows is that AIDS cases are going down, and AIDS deaths are going down, and so prevalence is increasing as more people are living. But again, we're not seeing a really difference in new infections. This was some revised estimates in 2006, but really the number of infections each year are about the same. The CDC recently put out some new data from 2006 through 2009, sort of the most up-to-date data, and they did see sort of a leveling off in all groups, except for the group that I work with, which is young, black, gay men. All right? That was really the only group where they actually continue to see an increase in HIV infections. So here's a list of the antiretroviral drugs. The ones in red are ones that are sort of really far along in development. There's some other ones I could add to this that are sort of in the earlier stage of development. But again, you can see there's a whole lot of drugs that are available. The truth is that we don't use all these anymore. Right? We've pared it down to the drugs that are the most effective and that are the best tolerated, and the ones that are in combination pills tend to be the ones we choose because they're easier to take. There's different classes that we use. Again, these are not for you to memorize. You don't get tests, right? Okay, good. So you don't even need to know this, but what I tell the residents that I work with on the wards is you should know sort of the names of them. To some extent, some of them sound the same. The protease inhibitors, darunavir, lopinavir, atazanavir. So if somebody sort of, bounce that off, if you're in the medical field, you sort of, okay, that sounds like an HIV drug because, that may obviously change sort of, at least when my residents admitting someone with something going on, that may be helpful. But, overall, I think, if you all knew every single one of those, then they wouldn't need me to do my job. So don't really learn these yet. And what we know is that people who are on medicines do better, okay? The medicines work, all right? The medicines work by suppressing the virus, and then that allows the body to do its thing, all right? I'm not a basic scientist, and that's how I understand it. There's a lot of other stuff that goes on, but, as I say to my patients, the medicines suppress the virus, the immune system can get back to doing the job it wants to do, but the virus isn't gone, right? So if you stop taking the medicine, the virus comes back, and you're sort of in the same spot you were in. What we also know is that, the body it doesn't like to have the virus replicating, all right? It doesn't like the presence of the virus sort of replicating on its own, being uncontrolled. It causes the body to be immune activated, sort of, I think of it sort of, in that state of sort of activation and on guard, and the organs of our body don't like that, all right? The kidneys don't like it, the heart doesn't like it, the brain doesn't like it. So even in people that aren't on therapy but have high CD4 counts, we can see sort of these changes related to sort of the virus itself. So what we're learning is that treating patients is good for the immune system to prevent sort of the opportunistic infections we'll talk about, but also to prevent some of the other things, sort of to keep the body happy, so to speak. And that's why we've moved sort of the pendulum of when we treat. And I'll talk to you a little bit about that right now. And so these are the guidelines. These are the guidelines based on the Department of Health and Human Services. They're this group of doctors, HIV specialists that get together, in quiet rooms and review data and, I don't know, drink coffee and decide this. And they make these tiny little changes every year and come out with, a new 98-page document. And basically what they sort of are making these guidelines of who should be treated and what they should be treated with, okay? And their most recent guidelines basically say, people that have sort of looking at their CD4 count, looking at their immune system, all right? If their CD4 count is low, less than 350, treat them. If their CD4 count is between 350 and 500, treat them. If their CD4 count is over 500, you probably should treat them, but you don't have to. So, not much difference. Treat, sure, treat. What you can see is that the balance is really towards treatment. It hasn't always been the case. If you looked at guidelines a couple years ago, for almost all of these, it would have said wait to treat, except for the people whose T cells were less than 200. And that's because the drugs weren't as potent. They were more likely to lead to people sort of having side effects to them because they were sort of more prone to that. And because they were lead to side effects, they would lead to people stopping taking them, and that would lead to resistance. We don't see that as much anymore. So the guidelines, again, the treatments are better. They're better tolerated. We know now that people even with higher CD4 counts do better on treatment. That has sort of pushed everyone to treat everyone. And the question really is not who to treat anymore, but who not to treat. There are very few people in my clinic that don't get on therapy, and those are really sort of exceptions that we'll talk about sort of why they would not be on treatment. There's other conditions, AIDS-defining illnesses, pregnancy, HIV-related nephropathy, hepatitis B, all these other things sort of play in. But the bottom line to take away is that most people with HIV should be on treatment. And if they're not, there's probably reasons that went into that decision. So again, we sort of went through this, but studies suggest lower CD4 counts, greater risk of heart disease, cancers, and dementia. Again, probably related to sort of the immune activation and the immune deficiency sort of combined. There's no study that shows harm in starting earlier. Okay, so the first do no harm. Well, there's no harm. Bad things tend to be rarer around people who have normal CD4 counts. Somebody comes into the hospital with a CD4 count of 500 and has chest pain, it's probably a heart attack rather than PCP pneumonia. Whereas somebody with a CD4 count less than 20, it's probably going to be PCP. So, we people with CD4 counts that are normal in the normal range get the normal things that we get. So when you think about clinical manifestations of HIV, again, it's probably, if they come in with a broken bone, it's a broken bone. It's not TB causing a broken bone, sort of, and I think that that message hasn't sort of gotten out to a lot of people in the medical profession. A lot of, I would say, and I'm not trying to be stereotypical, but, we'll get sort of people that have been seen out in the community who come in, again, sort of with chest pain, with a CD4 count that's very high, and they'll get worked up for PCP pneumonia, and nobody will look at their heart, despite the fact that they're a 50-year-old smoker with a family history of heart disease, and they'll end up that they had a heart attack the whole time they were being worked up for, PCP. So again, I think part of sort of thinking about HIV is recognizing that HIV does not equal AIDS, which is why, I think the course should be changed, the name. And again, the other sort of piece of it is that therapy can reduce infectiousness. So the Science article of the year this year, the breakthrough of the year was a study that was put on by my boss and people that he was working with, but basically showed that if you treat people and their viral load goes down and they have sex, that the HIV is not transmitted, all right? It's very, very, very rare for HIV to be transmitted with an undetectable viral load. Is it impossible? No. Is the risk zero? Do I tell my patients go out and have unprotected sex? No. But I think the truth is that treatment is prevention. And again, we treat the individual, but I think thinking about it in the public health sphere is not wrong to do as well. This is a study that basically showed, it just followed people over time, and it looked at sort of when people started HAART, or antiretroviral therapy, and it looked at their CD4 count. And what you saw is that, depending on where you started is sort of where you ended up. The people that started with a really low CD4 count didn't get as high as the people who started off in the normal range. So, the question is, and I sort of say this, is if I was diagnosed with HIV and my CD4 count was high, would I want it to get low before I started on the medicines, or would I want it to always stay in the normal range? And I think the answer is, from sort of where we are, is that it's better for it to stay high than for you to go down and then come back up, because you're never going to get back up to where you were before. So who should we not treat? All right, I think not everyone is ready. Okay, a new guy I saw today was an interesting kid. He was really guarded. A lot of the guys that I see, are just much more emotion. He was really guarded. He actually was diagnosed in 2010 when he was incarcerated, and this is the first time he entered care. So it's taken him a year and a half to enter care. And smart kid, but really had a lot of guard up, a lot of mistrust of me, the medical system. Even asked me, and I hadn't heard this in a long time, is it true that HIV was created by the government? And that is a myth that is still out there, but I hadn't heard it in a long time. He brought up Magic Johnson, which, again, I hadn't heard in a long time, especially from people that are young. He's 24, so, sort of what's Magic on? Does Magic really have HIV? Things like that. And wasn't sort of buying into HIV treatment yet. Sort of wasn't, he's not someone who I would have started yet. I usually don't start people on the first day anyway, but he clearly isn't there yet. He needs to believe in the medicines, or he's not going to take the medicines, okay? Considerations for deferral cost, again, I think, we try and make sure that if they're not getting the AIDS Drug Assistance Program, that we can get them pharmaceutical plans and copay assistance. But, for some people, there is sort of issues with cost. If people don't take their medicines, they can get resistance. Some of the regimens are less likely to see resistance, but we do see it. So it is, HIV is different than other diseases. If you have, hypertension and you don't take your pills, your blood pressure probably goes up, but, it's probably unlikely that you're going to get a stroke for missing your blood pressure 2 days a week. However, if you miss your HIV medicines a couple days a week, you may develop resistance, and that makes treatment harder and harder. Again, the question is, what CD4 count should we start people on? What if their CD4 count is 800? Do they need meds? What if their CD4 count is 799? Do they need meds? What if there's not a number. There's not a magic number. A lot of it just comes from, looking at the patient, talking to the patient, seeing what their expectations are, and sort of following them over time. As I say a lot, is that HIV is not typically an emergency. All right, it's very few emergencies in HIV, and when they are, it really is for the people that are pretty darn sick. Sort of like the guy I saw today. If he's not motivated, to take it, then don't do it. It has to be a joint decision. I can recommend things all I want, but if they're not going to sort of be on the team with me, I'm not going to push it, because I'm not sitting at home with them. I'm not calling them every day to take their medicines. So, I have 3 kids. I can barely get my 4-year-old to brush his teeth. I'm not trying to get this guy to take his medicine. So, he's got to be in the program with me. And it's okay if they're not right away. I think part of it is sort of, working with them and showing them, I'm going to see him in 2 weeks. I don't usually see people every 2 weeks. But, I think just sort of to show, I'm not going anywhere. I'm going to be the same person that I was, today as I am 2 weeks, and try and start to build some trust. Depression, we know that our depressed patients don't do as well. Depression takes all kinds of forms. One of the patients I saw today with a fellow, I'm not depressed. We started going through things. Well, yeah, I don't sleep well. Yeah, I have lost my interest in things. Yeah, sort of like, all those depression questions. It was like, check. But when you asked him, do you think you're depressed? Not really, no. And so, I think thinking about that and talking about sort of depression, in a non-judgmental way. People don't want to have mental illness. They don't want to be told they're crazy. But if you sort of frame it in the chemical imbalance kind of realm, I think it definitely has, get rid of some of that judgment. And then substance abuse. Again, I'm a firm believer. I don't think all substance abuse and use really portends whether somebody can be adherent or not. Again, this is why I couldn't run for office probably, but, I didn't, you hear me? Okay, you're touching your neck. So, again, one of the guys I saw today, he smokes weed every day. He takes his medicines every day, again, is it because it keeps him home? He's on a schedule, but, I don't know how much, marijuana really affects adherence, but, my guys that are using meth, it's clearly a problem in terms of taking their meds. One of the guys I saw today, uses cocaine pretty regularly. There are certain drugs, sort of, for me, that are sort of flags of, whether they're going to be adherents. Another one is sort of binging on alcohol, because, that tends to sort of make people not want to take their AAA on the nights that they're going to go out and get wasted. So again, it sort of leads to them missing doses. So again, I think it's not sort of just, oh, you use drugs, I'm not going to give you meds. It's sort of a more of a conversation. And again, these are sort of the same things. These are factors that are associated with people not doing as well on their meds. People that can't read, I didn't realize one of my patients, a Hispanic patient, who I always, work with a translator with, because my Spanish is, is enough to get me to understand, pain, hunger, where the bathroom is in foreign countries. But that's about it. So, but I didn't realize that he couldn't read. And so even in Spanish. And so, until we sort of got past that, he was getting appointment slips that he thought were bills. He was getting, things from the pharmacy that weren't bills, but they were, and so he wasn't going to get his meds. He wasn't coming to appointments because he thought he was being charged. So again, a lot of issues there. Depression, homelessness. The young kid I saw today is living out of his car. It makes it hard to be on medicines when your life is not stable. Okay. When you don't know where your next meal is coming from, he eats typically once a meal a day because he has a friend who works at Subway who sneaks him, sort of the sandwiches that are sort of, the yucky bread, he'll save him a sandwich every day. That's what he eats. So, again, these are sort of bigger issues to some extent. Again, we talked about substance abuse, stigma. There is still a lot of stigma alive and well in the South, in North Carolina. And it really does affect people's willingness to be on medicines, to have a pill bottle that says, an HIV medicine, to come to clinic, and things like that. These are the medicines that we use, okay? So this is, again, the second part of what the guidelines tell us is when to treat, but what to treat. It's really easy, okay? It's very easy to be me, all right? At least when they first come in. Because I got 4 choices. Okay? I actually have 2 choices because I picked the 2 that I like. So the first choice is AAA. It's 3 pills in 1. Okay? Efavirenz, tenofovir, and FTC. Again, you don't need to remember it. Just remember AAA, 1 pill. Okay? Pretty easy to take. Second regimens, all other 3 regimens, tenofovir, FTC. The TDF FTC is Truvada. So all the 3 other regimens, Truvada, plus you have 2 choices of protease inhibitors, atazanavir or darunavir, or you can use an integrase inhibitor, which is the raltegravir. So really you have 4 regimens to treat HIV if someone's newly diagnosed. You pick the ones you like, okay? I don't use the last one because it's twice a day. I don't think people who are newly started on medicine should have to take something twice a day. I don't do anything twice a day consistently at the same time, so I don't think that patients should have to. So that one I don't use. Darunavir and atazanavir are basically the same. The atazanavir can cause people to turn yellow a little bit in the eyes and the skin. My patients don't like that, so I don't tend to use that one. So for me, it's AAA or it's Truvada and darunavir. Pretty easy. These are the pill burden associated with it. And again, the first one, AAA. If you don't learn anything today, 1 pill once a day. Okay, so pill burden 1. food restrictions? Not really. We encourage people to take it at night because the side effects are less. But again, this isn't major stuff for you to know. Just to look and say, sort of the pill burden is very low. If you were really sort of to ask most patients when they're newly diagnosed how many pills they think they're going to need to be treated with, no one says, oh, isn't there one pill to treat HIV? Again, probably in California and New York, where I think there's a little bit of a higher literacy around HIV, people may know that. But, most of the young guys I see are pretty, hopeful when I tell them that we can treat their HIV with one pill. Long-term side effects, again, no drug is perfect. I think the perfect drug would be a Skittle. I love the fruit rainbow. But, where people just take, a green one day, a red one the other day, and they chew it and it's done, and there's no side effects. I don't think you can, even gain weight from one Skittle a day. So, but none of our pills are perfect, all right, which is, I think, where some of the art of being an HIV doctor comes in. You can see a lot of different things, side effects. Again, some of these medicines we don't use anymore because of the toxicities. So, the D drugs, DDI and D4T, really sort of toxic kind of drugs, so we don't use them much. AZT, very rarely used as much anymore, anemia. But some of the other regimens that we use all the time can cause longer-term side effects, which is why we do have to follow our patients. This is lipodystrophy, so the way I think about that is fat where you don't want it. Which in my case, I clearly have lipodystrophy, but not related to the meds. But, it's sort of losing fat in places where you don't want to lose it, in the face, all right, in the temporal, sort of wasting, in skinny arms, skinny legs, and gaining it where you don't necessarily want to gain it, so the belly, the buffalo hump, sort of the back, so sort of people who are on steroids, they sometimes get this type of side effects as well. So we tended to see this more. Interestingly, we saw it more with some of the older drugs that we use, the D drugs, but also we see more side effects in people that start later. So the people that start with lower CD4 counts, we tend to see more sort of these side effects. What about opportunistic infections? So again, this was, the reason I sort of went into ID was the first patient I saw at UVA as a med student had bad cryptococcal meningitis, and he had molluscum contagiosum, and he had all these different opportunistic infections, and I was fascinated, and he was this nice guy whose family didn't come because he was gay, and there was a lot of stigma in Virginia, and it impacted me quite a bit. We don't see as much opportunistic infections anymore, and it's because we have such good therapy. Now, clearly, if you go to the other parts of the world, you will see significantly more of that. Or even certain areas of the country where people are not accessing medications, we still see opportunistic infections. I think we see it most in North Carolina among our Hispanic population is where we tend to see people coming in pretty darn sick. We know that especially in North Carolina, the people that are most likely to test late are young Hispanic males. And we know that our antiretroviral therapy, we don't even call it HART anymore because all of the therapy we use now is highly active. So when we say antiretroviral therapy, that's enough. It really sort of reduces the incidence of opportunistic infections, reduces mortality, and again, really can sort of it's gotten rid of a lot of sort of what we think of or what we used to think of as AIDS. But we still do see some of these types of things, especially people that are sort of coming in, even with sort of CD4 counts that aren't significantly low, we can still see some of these early manifestations of HIV. All right, so I'm going to show you some pictures. I think they're pretty, but you may have another opinion. There's not, So this is, tuberculosis. I think, again, we are always on high alert for TB. We see cases of TB here, and not infrequently. People come in with sort of that lingering sort of wasting, fevers, night sweats. Chest x-ray doesn't look really, really great. And so, again, TB tends to show itself. It doesn't necessarily need your CD4 count to be 0 for you to see TB. Okay, so it's something that even in people with higher CD4 counts, we too see. We screen yearly with the PPD. We also are doing, for people that can't get them read, we do some of the newer tests, the blood tests to look, because we really want to make sure we're not missing TB reactivation.
How would you know looking at that
You wouldn't. You would have no idea. So, you know, I think that's sort of the bottom line is, you know, I mean, first of all, you know, I would say that's not a normal chest x-ray. Let's go to radiology, would be the first thing I'd say. And then you would look at the clinical history, right? So, you know, if it's an HIV patient who has certain symptoms, what you're probably going to do, what I would do if I was the Med-K attending, is I would put them in an isolation room to rule them out for TB, which means getting 3 sputums to look for AFB, or acid-fast bacilli. I would start them on therapy for probably community-acquired or hospital-acquired pneumonia, depending on sort of where they've been over the last few months. So I'd put them on antibiotics. I'd also look for other things that can cause pneumonia in our patients, so weird pneumonias, different infections, cryptococcal, which we'll talk about, typically cause a meningitis, but you can see a pneumonia. Histoplasmosis also can cause a pneumonia. Legionella can also cause pneumonia. So I'd look for these things. And if none of that showed anything, I'd call pulmonary and I'd tell them to bronch. And so we'd figure out what was going on. I'd also probably consider PCP, and we'd look into sputum for that as well. So I think, you know, you don't know what it is until you look for it. And there are very few radiological tests that are sort of diagnostic, especially in someone with HIV. So, you know, you're always going to sort of do the next step. Shingles, so varicella zoster infection, so, you know, reactivation, chickenpox, right? I said I was on Med-K over the holidays, and I saw a patient of one of my colleagues in the ER who, I think he was in his 50s or 60s, really compliant guy, and HIV viral load suppressed, CD4 count in the 500s, 600s, really compliant patient who basically came in with you know, a dermatomal outbreak, V1, so his eye, around his eye, his sort of scalp, with basically exactly like this, and severe pain. HIV was really well controlled, okay? But he's an older guy, so over 50, which is sort of a risk, and he had a lot of stress. 2 of his relatives had just been diagnosed with ALS, so sort of a progressive neuromuscular disorder. His sister was declining so fast that he had basically moved into her house to take care of her. So he was under huge amounts of stress and basically came in with shingles. So again, I think, you know, in him and in a lot of our patients, it had nothing sort of related. I mean, it was related to the HIV. His CD4 count wasn't 1,000. It wasn't perfect, but it was much more related probably to the recent stresses. See, these are the pretty pictures I was talking about, right? So genital herpes, again, we see you know, definitely more reactivation of genital herpes in our patients. We use a lot of Valtrex suppression in our patients and counseling as well. Hairy leukoplakia, which is caused by Epstein-Barr virus, so this, you know, the virus that causes mono, can basically cause, if you can sort of see it, it's sort of a white sort of fuzz or hair, hence the name, on the side of the tongue. It looks often like thrush, all right? Thrush is something we see sort of typically as our T cells are starting to get a little bit lower, but the hairy plakia, it doesn't scrape off, all right? So, you know, if you really are in a bad, you know, pissed off mood, you take a tongue depressor at your patient and try and scratch it off their tongue, it won't come off. But if you do that with thrush, it will sort of peel off. This is sort of the back of the palate, all right, with thrush. I often, again, when I'm on the wards and I'll see a patient with thrush is a candidal infections fungus. It's on all of us. We're all covered with fungus, you know, and, you know, don't ever let anybody come at you with a swab, and, you know, especially if you're in the hospital. But, you know, we're all covered with it, but when our body can't fight it, or when, you know, our immune system is weakened, we basically sort of get colonized. The colonization sort of becomes more of an infection. So our body doesn't sort of treat it, and the fungus is allowed to sort of to do its own thing, so to speak. We see this often with people that are on antibiotics, right? So women typically who are on antibiotics, the antibiotics kills sort of the good bacteria that sort of keeps the fungus at bay. So in addition to killing sort of the bad bacteria for your sinus infection, it also kills sort of the good bacteria in the gut or in the genital tract, and we see fungal infections, all right? So one of the first things that we often see in people that are not diagnosed is women will say they keep getting vaginal yeast infections. Also, that's another name for it, yeast infections, and they'll keep coming back. So these are sort of early things that we'll see that may be related to sort of HIV. Molluscum contagiosum, I just like to say this. This is a pox virus, right? Which is I just think it's kind of cool. Again, this is a sexually transmitted virus that causes these little, almost like, they look almost like little papules, I think if you like little teeny pearls with a little umbilicid center, right? So a little dot in the center. And these are caused by a pox virus. Typically, again, sexually transmitted, although people can really come in sort of with them all over their faces. And this is something you can see, again, people don't have to have very low CD4 counts to have this, all right? They're not, other than being cosmetically not the most, pleasant thing to have this on your penis, if you're one who has a penis. But, you're not gonna die of molluscum, all right? But we tend to refer people to get them treated. So again, if you were going to look at sort of your T cell count in sort of reference to the opportunistic infections people get, what you can see is, again, TB, shingles, all the things we were talking about earlier tend to happen when your T cell is not in the AIDS range, all right? So we tend to see that. As we move further, as people's immune system gets weaker and weaker, they're more at risk to get sort of these funky things, which are sort of the standard things that you think about with HIV. PCP sort of changes its name all the time. It's now pneumocystis jirovecii pneumonia. We still call it PCP. It used to be pneumocystis carinii pneumonia, but now the pneumo and the cystis still allows us to use the same name because nobody wanted to call it PJP. I don't know why. Doesn't look, this chest x-ray, again, if you ask the same question, I would not be able to tell. Typically, in a chest x-ray, you see sort of diffuse bilateral infiltrates with PCP. Could I tell you that that's not a bad community pneumonia? No. Could I tell you that's not, TB? No. Could I tell you that's not mycoplasma, sort of the typical just walking pneumonia? No. I mean, we would have to do specific tests to look for it. But clearly, it's something that you have to treat and think about. Toxoplasmosis, all right? Parasite. Again, we don't see it that often anymore. All right, you get it from cleaning the litter box of your cats. That's why you should have dogs. Sorry, I have a cat, but anyway. So it tends to present with sort of mass lesions in the brain. People present with all kinds of crazy symptoms. The last case I had basically presented with blindness, not good. And because really sort of he had these big lesions around his optic nerves and had a lot of increased pressure in his brain. So again, we treat this with antibiotics. Some people do very, very well. Other times people need shunts to drain the pressure. Again, see this in people that are pretty darn sick. Cryptococcal meningitis. Again, this is a picture of the cryptococcal spore or fungus. A fungal meningitis. Again, this is, we don't see it that much anymore. But again, the most recent time I was on Med-K, this was a guy, a 34-year-old guy, a pastor. And he'd been having headaches for a while, had gone to his local ER 3 times actually. Each time they gave him Demerol, a painkiller, and Phenergan, a nausea medicine, and sent him out and told him he was having migraines. Okay, came back the next day, or a couple days later, same thing, sent him out, same thing. Finally comes to UNC, is sort of tired of being sort of discharged, gets admitted to our service. We do a lumbar puncture, so a spinal tap. And the pressure in his spinal fluid is so high that you measure it with sort of this column that you sort of hook up to the needle, shoots out of the top of the spinal column. So, I mean, you should have seen the med student just, it was cute. So his intracranial pressure was so high, you could sort of just, in that, I looked at that and we said, cryptococcal meningitis. I mean, it's clear at that point. But turns out, and so we tested him for HIV, and he had AIDS, and his CD4 count was less than 10. Talking to him about his history, he was very open about, the fact that he had multiple sex partners, both men and women, in the past. He had a lot of stuff he was dealing with, but he was, currently in a relationship. He was engaged with his fiance, it was a really, it was like my Oprah moment, it was like, talking, we had a family meeting and we were there, myself and my intern, and he told his family about the diagnosis, and it was really pretty amazing because, she was listening and she didn't say anything and her head was down and he telling her how much he loves her and he's sorry. And, it was really, really meaningful. And she gets up and my intern and I are like, oh God, she's going to walk out. She's going to walk out. We're both, and she gets up and she walks over and she just hugs him. And everyone's crying, and but it was like, I felt like I was on Oprah, it was awesome, But he had cryptococcal meningitis, and he is finishing up his amphotericin, so his treatment for that. It's treatment for that for 2 weeks, and then you can switch to something a little less toxic, and then he'll see me in clinic next week, and we'll start him on treatment and get him, And as I said to him, you're going to do great, this was, the best thing that you did was keep coming back and demanding somebody acknowledge why you're having headaches. All right. The rest is easy. Again, I say I'm not that smart. I can treat HIV. I can deal with this stuff. So, CMV retinitis, CMV a virus. Again, typically causes sort of you and me, healthy people can present sort of like a mono. In people that don't have a good immune system, you can see all kinds of bad things with CMV. What's interesting, I think, is that with HIV patients, you tend to see it affect the eyes, CMV retinitis. People can go blind, all right? I'm not an eye doctor, but yellow is bad, red is good. So the eyes that have a lot of the yellow, sort of white stuff, not good eyes. Also in HIV patients, we used to see a lot of CMV colitis. People present with bloody diarrhea. In transplant people, sort of people that have received different transplant organs or bone marrows, they also are affected by CMV. They tend to get things like CMV pneumonia, which can be really sort of devastating as well, or hepatitis, as well as some of the other things that we see. Kaposi's sarcoma. This is also caused by a virus, human herpes virus 8. Okay, causes some other types of cancers, but KS used to we hadn't seen a lot of it in a while. And I have to say, in the last year, I've seen about 3 or 4 cases of really pretty impressive Kaposi's sarcoma. Can affect the skin. The point is that when it's on the skin, it's often internal as well. It can infect your lungs and cause bleeding in the lungs, hemorrhages in the GI tract. We had a young kid actually die, really of disseminated Kaposi's sarcoma. He was a patient that my fellow and I were taking care of, and really just a sweet kid who came in with such bad Kaposi's sarcoma that he was basically deformed. It had gone from this stage of being sort of the red and sort of bruising to basically sort of almost turning like if you had warts, sort of like cauliflower all over his legs with huge amounts of edema and swelling, and it affected all of his internal organs. And we got him on therapy with the oncologist. We got him on HIV meds. His HIV was actually responding. He was actually doing well from that standpoint, but they ran out of his chemotherapy. So there was a shortage of chemotherapy agent that's used to treat Kaposi's, and so they gave him sort of the second-line treatment, and that didn't really work as well. So then, and it made him sicker, so then he missed another chemotherapy visit because he didn't like that new one. And then he got admitted and subsequently died. So again, I think we don't see this as much. Again, if I can sort of count on my hands the amount of people I've seen with it, but clearly it's still, if you don't want to miss it. But again, I think the point to stress is that most of the people who are dying of HIV-related issues are dying of other things, okay? Violence, non-AIDS malignancies, okay? So we see a lot more increased rates of cancer in our patients that aren't necessarily related to the HIV. Heart disease, liver disease. The other point is that this is a survey looking at a sort of just a global survey of people with HIV. And I think the point is not to look at all these things, is that people with HIV have everything that people with not HIV don't have, right? Depression, sleep disorders, GI issues, cholesterol. So, what I say to my patients is, you're gonna get the runs. You're gonna, have a day when you don't feel good. You're gonna have a cold. It's probably related, to the Chinese food you ate the night before and not your HIV. Okay? All of the things that happen to you in life are not going to be related to the HIV. And, you have to sort of live your life and be cognizant of it, but not sort of, get so paranoid that every single thing you have means you now, your HIV is now AIDS, can make people kind of crazy. Again, what we do know is that cancer incidence, however, in our patients, even with higher CD4 counts, is higher, okay? So again, if you look at sort of the cases, these are the AIDS cases on the top, and then the non-AIDS cancers, so liver cancer, anal cancer, lung cancer, all of these cancers, the number is greater than 1, which means that people with HIV get them more often than people without HIV. Some of that may be due to lifestyle factors, all right? We know that anal cancer is driven by a virus called HPV, human papillomavirus, the same virus that causes cervical cancer, causes anal cancer. So I do anal pap smears in all my patients yearly. They don't love them, but I try and say that, they're a lot better than being up in the stirrups and having a female pap smear, so they need to be quiet. But it's, again, these are all some of these are preventable. We know that, again, our patients who smoke are more likely to get lung cancer than HIV uninfected smokers. So again, these are all sort of things to sort of talk to them about, is that, why do you want to die of these other things that are preventable when you're not going to die of your HIV? Again, this is sort of the talking about the lung cancer, higher rates in our patients. Oh. And that was all that I had.